Thank you very much for this kind introduction. My name is Sarah Valks. I'm with the team from the University of Antwerp. My colleague Greet will first briefly situate this initiative within the broader frame of the Coalition for Vaccination and the IMMUNION project, after which we can kick off with the first speaker.
Good morning from my side again. Thank you for the introduction. So I would like to situate the IMMUNION project and what we are coming to do to put this all up in your meeting. I would like to situate the IMMUNION project and the coalition. So in 2014, the European Commission took an initiative to promote more vaccination and to strengthen the vaccination coverage on its own. And therefore, they created in 2018 the coalition, as already said, the Coalition for Vaccination, that is currently led by the Nurse Federation, by CPME then, and by PGU. To strengthen the coverage of vaccines and to at least make the vaccines in the attention of a lot of healthcare providers. So the coalition itself doesn't contain these three organizations, but it's also a huge amount of organizations of healthcare providers. It goes from dentists, but also student associations are linked to this coalition. To support this coalition, a call was launched where we, and especially Eurohetnet, applied on it with some people that created a project and a project proposal that at the end was granted as IMMUNION. So IMMUNION helps to streamline the communication of the coalition, but also helps to get the vaccination again to the attention of the people, but also especially to the attention of the healthcare providers. So this is a 2 years project. It's going from 2021 to 2023 with several work packages, and we as the University of Antwerp, we are leading work package 5, where we are responsible for training on communication. So in first part we will organize a train the trainers workshop, where we will train people who can train healthcare providers to talk about communication. But we also would like to get the attention from associations like CPME, associations like the students, and therefore we create this kind of sessions that we are organizing now. We are apart from the University of Antwerp, the vaccine, so the Center for Evaluation of Vaccination at the University of Antwerp. We are the research part of that group that is led by Pierre van Dam. So the 4 people that are currently working on the project is Brenda Janssen, who is sitting over there, Aurélie is sitting here, and Sarah, and I am trying to guide this project in a certain way. So it's also important to mention that the European hub of the Vaccine Confidence Project of Heidi Larsen also is embedded in our university. So we have an expertise on confidence and on training, and that we would like to bring together, especially also here in this session. So what is the objective of our session here is that we do an advocacy for vaccinology in healthcare providers, especially with a focus on communication. So this session that we are now doing is not really the technical issues on vaccines, but it is really how to communicate about vaccines. How can a doctor or another healthcare provider communicate about vaccines? The preventive way of really answering questions, taking away the mistrust of vaccination. And that is what we want to tackle in a nutshell here in this session. So on the program, for the people who doesn't got the flyer on their desk but are at home, we will have Brett Craig from WHO, who will start to give an overview on the role of the healthcare provider in this process of vaccination. Then we will have most are online, will come in the meeting online. So we have Heidi Larsen, who will give an overview on the vaccine confidence in Europe. And we have Angelo Fasces, who will more go into depth, more in techniques, how to communicate together with Dan Hollard, that also will focus on the communication part itself, and that will make it very practical. At the end, we will end up with a panel of experts, and then we are putting the work in your hands. We really want to have your questions, and this panel is here to answer all your questions on the questions you can have on communication. So the people that are online can put the questions in the chat. So I hope we have a very fruitful meeting, and Sarah will guide you through the whole meeting. Thank you for your attention.
We can kick off with the first speaker, who is Brett Gregg. Brett Gregg is a technical officer in the Vaccine Preventable Diseases and Immunization Program in the WHO Regional Office for Europe, specifically working on vaccine acceptance and demand. He has been primarily coordinating in-country support on COVID-19 vaccine acceptance and demand activities for the region. Brett has a background in social science research, social and behavior change and communication, and has experience with gathering insights and designing interventions, including trainings in the area of new vaccine introduction and provider-patient communication in primary healthcare settings. So Brett, thank you for joining, and the floor is yours.
Good morning, everyone. I'm happy to be with you today, and I'm happy to just start off this session. So let me just get started a bit by reviewing what many of you already know is that healthcare providers are extremely important and influential in impacting vaccine confidence in patients. They are the most trusted advisors and influencers of vaccination decisions, and we've known this for quite some time. The provider's strong recommendation is a strong facilitator of vaccination uptake. The provider's relationship with patients supports them in their decision whether to vaccinate or not. And also, patients require consistent and accurate information about vaccine safety and benefits from all their healthcare providers. And it needs to be communicated or conveyed in a respectful and positive manner. And so, unfortunately, that works the other way as well, that providers possibly can have a negative influence on patients' decision about vaccination. And they also may underestimate their influence or their ability to influence the patient's decisions and the importance of that. They might not take the time to talk about vaccination, and they might themselves lack confidence in the vaccines, and that can come across as well to their patients. But however, if healthcare workers are strengthened, if their confidence is strengthened and their skill set is strengthened, and their perspective is one that understands the importance of their communication and their relationship with their patients regarding this important topic, then providers can, a recommendation from provider can be a major driver for vaccine uptake. And so shifting a bit to just some overview of what we've learned through COVID-19. So just a couple of brief insights. The results of the behavioral insight surveys show that trust in healthcare providers increases both the intention to vaccinate and also the likeliness to have been vaccinated against COVID-19. And so likewise, data from several countries more recently through December and January show that those with high intention to vaccinate are much more likely to trust the healthcare provider who would actually administer the shot. And so this is from quantitative data surveys across countries. And this has been very helpful to again, strengthen that previous knowledge that we had of that healthcare providers are very important in this decision. They continue to be the most trusted source. But with this next bit of information, I'd like to actually take that a little bit deeper. And then the converse is also true, that consequently lower levels of trust in healthcare providers is a driver of low vaccination intention or of being unvaccinated as well. We have been able to dive quite a bit deeper with some qualitative research in many countries in the region. And one thing that we have consistently found is that not only does this hold true when we do the qualitative research, especially among those vulnerable groups, such as older adults, but that there's a lot more depth to that to understand why it is that healthcare providers are the most trusted source, or that when there is lack of trust in healthcare providers, why it affects vaccination uptake. So let me just briefly give an introduction to this qualitative research that we have been doing. We've published a rapid qualitative research tool, and the design of the research tool is not only to conduct the research, but to conduct it in a way that can be that can directly influence or inform interventions that can be tailored to specific target groups. So instead of looking at across the entire population, the qualitative research zooms in onto specific subgroups within the population, such as older adults, comparing urban rural as an example. And this can provide more of a description from the perspectives of these target group members, why they have chosen to vaccinate or not, plus other barriers that exist and drivers to vaccination. Just as an overview, we started with health workers as the first priority group, and many countries participated in that. And now we've done quite a few with other population groups, primarily older adults and those with underlying conditions. And the work continues to go forward in many countries in the region. And so just some of the insights or findings from this research that I want to share today, because it's very relevant to what we're talking about, has to do with both the information that patients have or don't have, as well as the trust and the reasons for trusting or not trusting in healthcare providers, and why it matters so much with vaccination. So just a few points on the insights. First, in terms of their knowledge, knowledge about COVID-19 vaccines still remains fairly low, both among patients, but also among many healthcare providers. Confusion occurs with the abundance of information about vaccine safety and effectiveness, different vaccine products available in different countries, etc. Unfortunately, much information still is not available in local languages. And so not only patients, but even healthcare providers sometimes still don't have most updated information or information that they can be confident in. Regarding their attitudes and intentions towards vaccination, concerns that this is among patients, concerns that their age or their chronic conditions or feelings of frailty, for example, or unwellness, they have a fear that that increases the risk of complications with COVID-19 vaccination. This leads to beliefs that they would need a thorough medical examination before receiving a vaccine to make sure that it's safe for them individually. But sometimes these exams can cost money, and that can present another artificial barrier for them as well. Some more insights have to do with health worker recommendations. And so again, the social environment that many people find themselves in, a recommendation from a health worker is still generally a trusted source, and many healthcare professionals across the region see themselves as such, and that's a very positive thing. However, many healthcare providers or health workers also may still not be promoting vaccination, especially against COVID-19, especially if they're not directly involved in vaccination. And it might be that it is seen as something that is tangential or something done by others, and so it's not integrated into primary care, for example. Health workers also may still have insufficient information, and it causes them to lack confidence, or at least provide incorrect recommendations. Some among elderly groups, because of this, also doubt that their health workers, even if they're trusted, but they might not fully have confidence that their healthcare providers have all the most up-to-date knowledge about vaccine safety and effectiveness. And again, many report that there's insufficient positive information in the media about vaccination, about safety and effectiveness, which again strengthens the need for healthcare professionals who are trusted to be communicating about these vaccines. Many opinion leaders in societies and in smaller communities also can be vaccine hesitant, or at least not willing to promote vaccination, not wanting to be confident in it and be actively promoting it because if it's seen as sensitive or politically charged. And so a lot of combating misinformation and building trust needs to occur at local levels. And this is often, again, down to the very level of local healthcare providers who are known to their communities, who are known to their patients. One of the main areas, again, is this role that healthcare providers have. Why is it that they are the most trusted? And what is it that many patients are expecting from healthcare providers? What we've learned through this research on COVID-19 vaccination, as an example, is that, yes, the health workers are trusted, but it's not just because they are health workers or healthcare providers, and it's not just whether the vaccines are safe in general, but rather it is the healthcare providers' familiarity with their individual patients' health conditions, as well as their willingness to address individual concerns specific to the patient that makes patients want a personal recommendation to get vaccinated. So what that means is basically because of a lot of concerns about safety, not just safety of the vaccines being new, which is definitely a concern of many, but actually the unknown of how is this vaccine going to react with my current health status, with the way I'm feeling, with my current chronic conditions, with has it been tested on people like me? I'm not sure if it's safe, etc. And this is really why people want that personal recommendation. They want their healthcare provider who knows their health history, who knows their current condition, who hopefully is an expert enough to be able to say, I understand your concerns, and this is still a strong recommendation. This is why you need to be vaccinated against COVID-19. That we still continue to focus on this role of healthcare providers, but that personal relationship with patients, not only as experts, but as ones who can understand what is best for their patients and understand what the concerns are, but also understand their health and understand why that recommendation is so important on a personalized, tailored level in order to increase confidence, not just in vaccines generally, but individually for them, that it's the best thing for them, each patient one-on-one. So thank you. That is all, and I'm happy to answer questions later on about this.
The second speaker is Hedy Larsson. Hedy is Professor of Anthropology, Risk and Decision Science, and is the founding director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. She is also Clinical Professor of Health Metrics Sciences at the University of Washington in Seattle, and Hedy has also recently joined our team as professor. She previously headed the Global Immunization Communication at UNICEF, chaired Gavi's Advocacy Task Force, and served on the WHO SAGE Working Group on Vaccine Hesitancy. The Vaccine Confidence Project is a WHO Center of Excellence on addressing vaccine hesitancy. Her research focuses on the analysis of social and political factors that can affect uptake of health interventions and influence policies, and her particular interest is on risk and rumor management from clinical trials to delivery and building public trust. So Hedy, please go ahead, the floor is yours.
Thanks, and happy to join you this morning, and appreciate the convening on this important topic here. I'll just give you just to quickly introduce the tenets of the Vaccine Confidence Project. From early days of our research, when we started 12, 13 years ago, we recognized soon from our findings that this wasn't really just an issue of confidence in the vaccine itself, the product, but it also, as we've just heard, it's about the confidence in the provider, and as well as policymakers and systems, which has become particularly a particularly significant issue in the context of COVID. In 2015, I think a number of you are familiar with this study, we did the first global mapping with a comparable metric on what is the state of people's confidence in the safety, effectiveness, and importance of vaccines, because what we found that actually a perception of the importance of the vaccine was the most important lever of actual acceptance. If you don't think vaccines are important, it doesn't matter if you think they're safe or effective, because you just don't think they're important enough. So that was it was kind of our formative baseline research. We've been monitoring since, and we're just now in collaboration with the Antwerp team we've been every 2 years since this study, we've been with the EC, with the EU, doing monitoring across Europe, 2018, 2020, and now we've just started 2022. We'll be very interested in seeing the impact of COVID on confidence. But in 2020, we published this bigger report on the data the index we've been running globally to look at the difference between 2015 and 2018. And it looks like Europe, and we've seen this in other studies too, actually started getting more confident, getting better. And this was largely the EU and the Europe itself recognizing the importance of this issue and being proactive with the joint coalition on vaccines and other efforts. And I think this was particularly also reignited by the serious situation with measles. We have in all of our data, we have all the background socioeconomic and other factors around our participants. And one of the things that's really struck us during COVID, as I mentioned, it's always been in the mix of factors affecting vaccine acceptance. But in COVID, we've seen that the overwhelming, more than any other socioeconomic and demographic factor, how the government was handling the COVID response was the most important lever of willingness to accept the vaccine. And that was not by a small margin. One of the big challenges in this context is the usual communications just it's not the same. We're dealing with group issues. We're dealing with population level activism and the normal kind of communication that you might want to do in a clinic context or even in a small level is not going to hold water when you're moved by a larger group of people in these protest movements. And that's the kind of situation I think we need a separate track for, a separate context, and most importantly, to keep pulling the lens back to look at the swarms of group behavior as we're building more individual level confidence. But it's a challenging environment, and we really need to look and have strategies that disaggregate individual to group to population-wide challenges. Some of these protests have been quite aggressive. It's not that we haven't seen them before COVID, but the level of emotion in these have been quite strong. Even in the UK, which has not been, there were protests around smallpox in the 1800s, but the level of protests also raised there, including NHS staff. And this was a bit different. This is not typical NHS staff behavior to put all of, to go to the Trafalgar Square and protest. These protests were not about the quality, the safety of vaccines. This was about the mandate. And this is a different level of issue. In fact, it evokes the very first anti-vaccination league in the world, or at least reported, was in the UK in the 1800s around smallpox. But it wasn't about the vaccine; it was the anti-compulsory vaccination league. So this whole issue of feeling compulsion has been a challenge, as all of you, I'm sure, know well, and not just with the public, but also among healthcare workers and professionals. So do mandates work? The reality is they do work. We've seen around measles in France and Italy in particular, who increased the number of vaccines to include measles and for school entry. It definitely did improve uptake. In the US too, we've seen that where school-based requirements are there, and when they're relaxed, acceptance drops a bit, but when there's more requirements, requirements to actually opt out, when it becomes, you have to do an interview, you have to make sure that the parent is fully conscious of what the implications of their decisions to opt out are. The more layers of that kind of, you have to go through this consultation before you opt out, they wouldn't bother, they'd just take the vaccine. So mandates and structural interventions can work, but the question is, and this has been a fascinating study by France, how long do they work? This new recent research that came out found that with the French health pass, it might have encouraged some who are hesitant or reluctant, but doesn't change the underlying sentiments, the underlying hesitance. They do it because of other functional reasons. They want to go to that rock concert, that cafe. They want to socialize with people, but they're not. Their underlying feelings about vaccines have not changed. It's more of a functional decision. In fact, and what I think is unique about this research, and we should think about it in other settings, when you're getting your vaccine, how did you feel? Were you relieved? Did you regret? Were you even angry? And I think this is an important framing. And the reality is that there was quite a bit of anger, and I mean, there was, the yellow line is agreed. I'm angry to have been vaccinated. This is the yellow line. So you don't want people, I mean, when I got my vaccine, and I'm sure for most of you, when you get your vaccine, felt an incredible sense of relief. But that's not true for everyone. And these are we need, as we move out of COVID, or at least temporarily, and go in looking at vaccines more broadly, people are going to have different emotions that they went through in COVID, and we need to handle that carefully. In another article that was about vaccine mandates, it stresses the importance about the mandate alone. You can't, that's not going to be a fix-it solution. You need to embed it in broader efforts of public trust and support. And this is where my first point about we can't just be looking at an individual level communication, which is limited, to, or a system-wide mandate. You need constant trust building. And the constant part is really one of the biggest things that we have to take away from the COVID experience. In a recent article I did with my colleagues here in Antwerp, with Griet and Pierre van Damme, we did a invited piece for the Lancet on new challenges, and we had very specific recommendations about the local level knowledge, which we just heard in the previous presentation. So you need the local, but you also need to keep this multi-level approach. This was, I'm looking back at our SAGE model when I was with the Vaccine Hesitancy Working Group for WHO SAGE group. We kind of parsed out in our systematic review of all the literature out there on this topic at the time. There's a lot more now, but still these issues of the vaccine specific issue, the individual group influences, and the contextual influences. And it's not one or the other, but again, this idea of a multi-layered approach During COVID, you've already heard some data, and there'll be more. The reasons, the factors for healthcare professionals are pretty similar to the general public in terms of their concerns, except for the workload due to the pandemic. But I guess people who have their own workload and homeschooling and whatever they had to do also could have been a barrier, but it's a different type of stress. And in the US, again, the top level things were unknown risks, insufficient data, concerns about side effects. And this has been a uniquely specific challenge to COVID vaccine because it is so new and the data is evolving. I mean, we're learning more every day, and there's new vaccines even coming down the pipeline for COVID, which does set it in a slightly different category than the routine vaccinations, which are far more familiar, and people, familiarity breeds trust. Uncertainty breeds distrust. So this has been a special challenge on top of all the other issues. We're looking more and more into the emotional dynamics of around vaccines, because it's beyond the behavioral and the intentional and all that, this kind of fuzzy or difficult area, but needs to be characterized better. And we just, from the spectrum of leveraging hope and optimism to help alleviate some of the anxiety and fear. This is Paul Slovic is one of my heroes in terms of my risk research. He talks about not only risk as analysis, which is more classic in medical and health literature, but risk as feelings. We're much better at risk as analysis, but less good at appreciating the fact that people don't, in part, they analyze, the risks of the vaccine versus the risks of the disease, but also a lot of it is emotions about other things they've been exposed to, personal anxieties, personal histories, and that. I'm a fellow with the World Economic Forum, and as one of the initiatives I did with some of the Economic Forum partners, this was with one of the forum partners who leads a very large social media analytics company out of Silicon Valley and does a lot of huge scale, way beyond what as an academic institution we could afford, but as a pro bono initiative offered to run some key questions. And we looked at COVID vaccine conversations around the world to see what was on top, and this was billions of data points. And the main thing we saw, the biggest takeaway was the most positive, positive conversation generating, positive sentiment. It would start and promote positive conversations is the word protection. It was so much more powerful in generating the hope, optimism, positive intention than prevention or stop infection. On the other extreme, any language that suggested it's a moral obligation. It's a requirement. You should, that morality judgment created immediate kickback, immediate negative messages, and really shut down conversations. It was quite striking because we were looking at swarms of data, and it was quite an opposite effect of the notion of protection. As we heard, trusted messengers are key, the safety in systems, and does it work? So just my last couple slides are really to say, while on the one hand, there is an importance of looking at behavior, we really need to not lose sight of the importance of context and experience, and just making the, especially with this hyper uncertain environment of COVID and the new vaccines, as comfortable, as familiar, as easy, in emotionally easy, comfort easy as possible, because it's going to be important not only for this vaccine, but for keeping that confidence moving forward. And the other piece, and this is a article I wrote in Science with a colleague and an engineering colleague, actually, who's also, we're looking a lot at systems and dynamics. The sentiments around vaccines have been hyper volatile. You can see the number of surveys that have gone on again and again, and you compare two, and they're never the same. They can be generally the same, but you always have to look at the date and time, because this has been a highly volatile time. And I think moving forward, we have to recognize that you might find somebody who seems quite confident, but don't count on that. We cannot rest on our laurels of either people's confidence in their vaccine or their trust in their providers. This is something that needs constant vigilance, constant trust building, constant renewing, because this is a very different landscape than we had certainly 10 years ago. And we have a lot of gardening to do, as I call it. This is our website. We're increasingly calling it the Confidence Project because it's beyond vaccines. And thanks very much.
Thank you, Heidi, for this very insightful talk. I think we can go ahead with the next presentation, who will be specifically about communication about vaccines. That presentation will be given to you by Angelo Faché and Don Holford. Angelo is a research fellow of the JITSUVAX Age 2020 project at the University of Coimbra. His current line of research focuses on the social dynamics and cognitive processes involved in science denial from a philosophical and psychological perspective. He will be assisted by Dawn Holford, who is online. Dawn is a behavioral science researcher with an interest in the psychology of communication. She's also part of the JITSUVAX team, but then at the University of Bristol, and they investigate vaccine confidence among healthcare professionals and the development of jiu-jitsu interventions against misinformation to be used in healthcare professional trainings. Their aim is to help healthcare professionals with tools for communicating better about vaccination. So please go ahead, the floor is yours.
Okay, first of all, I would like to thank the IMMUNION Coalition for the invitation to be here representing the JITSUVAX project. I'm also very happy to talk after Heidi because our project is to a large extent based on the knowledge it has been producing during the last years. It's a real honor to be here. Our project, the JITSUVAX project, aims at producing interventions to address vaccine hesitancy from a communicative or argumental perspective. So we want to develop interventions in which physicians can talk with their patients about the deep concerns or the deep arguments or the explicit arguments they have in mind when they reject getting a vaccine. I don't know why I can, okay, now. Vaccine hesitancy is actually a big problem across the European continent. We're particularly proud in the Iberian Peninsula about our vaccine coverage. It's around, well, in Spain it's around 85%, and in Portugal is greater than the 90%. But the most part of the Western European countries seem to be stuck at around the 75%. So the number of unvaccinated citizens in Western countries are between 25 and 30% of the population. The situation is more alarming in the Eastern countries, in which the unvaccinated population is of around 30 and 40%. So our approach to this alarming problem is to understand where is the hesitancy coming from. So we use this concept of attitude root, defined by Hornsen and Feeling as the beliefs, ideologies, fears, and identity issues that motivate people to want to reject scientific consensus. I think an attitude root is not anything new. It's just a new word for psychological construct, right? So an attitude root typically refer to a well-established psychological construct. Some of them are well documented and have been thoroughly researched by or investigated by psychologists during the last decades. For example, conspiracist ideation, distrust, fear, reactance. We have developed a taxonomy of anti-vaccination arguments with, and we have identified 11 of these very relevant attitude roots involved in vaccine hesitancy. Conspiracist ideation is well known, refers to conspiracy theories. Distrust can be focused on institutions, physicians. It refers to interpersonal trust, but also, trust on social institutions. What are the beliefs? Here we include pseudoscientific beliefs, impossible causal relationships like the belief that vaccines cause autism. We also include beliefs in the superiority of the natural remedies or alternative medicine. Then worldview and politics. Here we include libertarianism, some forms of anti-scientific populism. Then we have religious concerns. These are also well known, I think. And moral concerns. Here people manifest their concerns about unethical experimentation. Sometimes other concerns, moral concerns focused on a specific kind of vaccine, for example, concerns about the sexual activity of young girls around the HPV vaccine. Fear and phobias, also fear of side effects, distorted risk perception, in which people tend to think that the risk of the vaccine outweighed the risk of the disease itself. The idea that vaccines are not necessary because they have a very strong immune system, for example, is included here. Selfishness, typically free riding, the idea that, well, I don't need to get the vaccine because all the people around me have the vaccine, so I can take advantage of community or collective immunity. Then epistemic relativism, this one is new. It's more philosophically charged, I think. Is the idea, this postmodern conception of truth, in which truth is something relative, and science is just a discourse, typically a Western discourse. And then reactance, which is emotional reaction against being, obligated by an authority to do something, right? Not obligated, but compelled. We also identified 62 themes. Some of these attitude roots includes a thematic spectrum, for example, 5, 7, 9 themes. For example, conspiracy ideation includes 5 different themes: government cover-up, the idea that health authorities and companies conspiring to withhold important information from the public; conspiracy theories around big pharma; conspiracy theories around population control. Vaccines are a way to sterilize, depopulate, or track the existing population. Made-up treat, vaccine-preventable diseases are exaggerated or do not exist, or conspiracy theories about disadvantaged minorities, the idea that vaccines are intended to harm disadvantaged groups or poor countries. If you look at this word cloud, these are the most frequent words within each of these roots, a set of arguments. The first one is worldview and politics. For example, you can see that people is talking about civil liberties, politics, authorities, elite, government. And the second one is about moral concerns. People is talking about abortion, sexual activity caused by the HPV vaccine. We conducted a literature review of 152 scientific arguments, reporting anti-vaccination arguments from 44 different countries. And these are the frequency, the blue bars represent the literature review. And this is the frequency in which these scholars discuss or mention, at least they mention, these anti-vaccination arguments. Then we conducted a second review of fact checks about COVID-19 misinformation claims. These are represented by red bars. And well, you can see that they tend to overlap. So journalists and scholars tend to analyze the same kind of arguments, contrarian arguments. Fear and phobia, distrust, and unwarranted beliefs tend to be dominant in the academic literature and in the news. However, we also measured the agreement among the general population using a sample coming from the British population. And well, it hardly overlaps with the academic literature. So there are some attitude roots that are being overlooked by the academics. More specifically, reactance and epistemic relativism tend to be particularly important and are not being subjected to academic analysis. So how to address anti-vaccination arguments? We're developing an empathetic approach in which patients' psychological attributes are often considered an asset rather than a setback. This is a two-step process. First, an empathetic affirmation of the patient's concerns, and second, a rebuttal of the argument, redirecting the attitude roots. We are not developing a confrontational, refutational style. I mean, we don't want to argue with the patient. We want to understand, affirm their concerns, and then once we understand the attitude roots that is playing a relevant role here, try to use that attitude roots to redirect it and convince the patient to get the vaccine. Okay, let's see 3 examples of this. The first one is about the theme on alternative medicine. It belongs to unwarranted beliefs. The argument says traditional natural remedies have a similar record of healing and no side effects. Okay, so in this case, the affirmation, we're implementing a very cool website with these 62 rebuttals. We're still working on it, but we will be very happy to share with the Immunion Coalition once it's ready. Many people use alternative and traditional medicine without negative consequences. It is understandable to want to complete our medical treatment with remedies that fit our lifestyles and outlook on health. Many of these alternative medicine are even presented as safer and more natural than medical treatments, so they are very appealing. So here we are not trying to debunk alternative medicine. We are not trying to say that, you know, there is no evidence of effectiveness. You should not take this homeopathy or chiropractic or even no-shots, homeopathic vaccines. But we're trying to understand that, well, these remedies or alternative remedies tend to be very appealing. So it's normal to try to prefer them because they fit our worldview, right? Even if we know that there is no evidence of effectiveness for no-shots. The rebuttal will be something like vaccines have a long-standing record of effectiveness in boosting the body's natural immune response. especially when it comes to dangerous diseases that our immune systems struggle with. For example, COVID-19 vaccinations have saved nearly 500,000 lives in less than a year through generating natural immune protection without suffering the symptoms of the disease. Vaccinations are thus our first line of defense for these diseases, or to put it another way, vaccinations are nature at its best. So in this case, we're using the preferences toward natural remedies to say, you know what, vaccines are actually very natural. They just boost the natural immune system. Of course, there's a very dangerous red line between misinforming the patients and using their attitude route. In this case, we have to be very careful that we are giving them the correct information, accurate information, right? A second example will be this argument on science-related populism. Science and scientists are belonging to a maligned elite group opposed to ordinary people. This is very widespread. It's on the news and very common in social media, right? Like a conception of scientists as a maligned elite against the good people. The affirmation will be something like, it is understandable to have a negative view of scientists. They often seem like an approachable group of people, and this is true, who work separately from the rest of us and don't understand our concerns. Unfortunately, scientists often do not communicate effectively and so make it hard for people to understand or access research findings and evidence. This is also difficult even for us, for scientists. So yes, it's normal to have this point of view. If we look at how the scientific community works, sometimes it's understandable to think that we are an elite working without taking care about the general society, right? The rebuttal will be something like, the scientific community is a very diverse group of professionals where people of all ideologies and from many countries collaborate, exchange results, and if possible, reach consensus. Scientists are not that different from the rest of society. They have our same concerns, are equally affected by political decisions. In fact, scientists often have big problems with political powers because some scientific results are uncomfortable for them. It does not make sense to adopt an us versus them thinking when problems affect us all. We are all in this together. So in this case, we are redirecting the route, this us versus them conception of society toward political powers. And we're saying that, you know, we are together in this. Actually, I'm just a physician, but I'm a normal person. And actually, we also have, as a collective, problems with political powers. And scientists have a long story of struggles with politicians, right? Of course, you don't need to agree with this. It's just a way to convince the patient, right? Then last example will be this about impurity. This belongs to religious concerns. Vaccines contain materials that are prohibited, for example, porcine products and fetal seals. To affirm this argument, we will say something like, people's religious convictions must be respected, and it is understandable to worry about the compatibility between dietary laws and vaccines. We want our decisions to be consistent with our deepest beliefs and values, but the message we receive from our religious leader can often be confusing and contradictory. So, well, if you hold strong religious feelings, it's normal to be concerned about vaccines if they fit our deepest values and beliefs. That's how we affirm this argument, and we create an empathetic environment with the patient. Then to rebut this, we can say something that the main leaders of the world's major religions support and encourage vaccinations, considering that there is no contradiction with their beliefs. and this includes Christianity, Islam, Judaism, Buddhism, and Hinduism. Vaccinations only contain materials that might be a religious concern in rare cases, and even then in very low concentrations. The protection of human life is always an act of love for God's work and the neighbor, which is in line with the core idea of almost all religions. So here we're trying to use religion as an asset to convince the patient to get the vaccine. You know, what is more Christian than the act of love of getting the vaccine and protect your neighborhood? Instead of taking a confrontational approach, we try to refute or debunk religious beliefs, right? To learn more about these attitude roots, myths, my project has edited a very interesting handbook on communication about COVID-19 vaccine. This handbook has been translated to many languages, some of them European. And my colleague Dawn Halford will talk about this because she has been the editor of this handbook.
Yeah, so thank you very much, Angelo, and good morning, everyone. I'm Dawn Halford, and I'd just like to share a bit more about how we've been trying to put together practical guidance that can be used by healthcare professionals such as yourselves or anyone really who wants to be able to communicate better about vaccines. So as we've already seen from Angelo's slide, we had a handbook that consolidated the existing scientific knowledge from different sources, which basically seeks to explain the facts about vaccines, especially in the context of COVID-19. So we talk about why we should vaccinate, generally what facilitates vaccine uptake. And on the flip side, we also look at what increases hesitancy, and we look a bit about what should be on the communication agenda for COVID-19 vaccines. So I think on the previous slide, we had the link where you can download the book, but I'll just get another bit more up here. Okay, great. Should be able to see my slides now. So the unique thing about the handbook I would like to really illustrate is that beyond the PDF version that just presents a very concise facts, general guidance, we actually include little click-through buttons in the sections that will give you more information about the subject. And this is in an online wiki, which is also at the same link, which I think was on Angela's previous slides, but we can get that distributed. And the reason for this is that it gives us more flexibility to find and add on emerging knowledge as it develops as we go on, because now we are more than a year into the vaccine rollout. This handbook, we published it in January last year, so things keep progressing very quickly. So as an example, inside the handbook, this is a screenshot of the page of the handbook itself. We started with a table of myths that we anticipated back in January. So if you think of this as a sort of starter for what sort of rebuttals we could make, we need to keep updating this because new concerns come up along over time. We have new research like what Angelo has just presented. And so we add new myths to our wiki page, the online version, which looks a bit like that. And then you can see we have a whole list of different myths and the facts against them. So hopefully this becomes a more valuable resource that you can use. And of course, we'd be very happy to take more questions about it in the Q&A, as I'm keeping this quite brief because I know that we are probably over time a bit. So thank you very much.
So thank you very much also for this very interesting presentation. We can indeed move on to the Q&A part of this session. For the Q&A part, we have assembled an expert panel, which consists of the speakers who I've already introduced. But those experts will be accompanied by one other expert, which is Aurélie de Waele, who is a postdoc from our team, and also an assistant professor at the Department of Communication Studies at the University of Antwerp. She holds a PhD in communication sciences, and her research interests focus on communication concerning vaccination, crisis communication, and corporate communication. And she has a special interest in non-verbal aspects of communication. To kick off the Q&A session, I would like to start with a question which I would directly address to Aurélie by means of introduction. So I think maybe many of you might have the same question. What should we do with patients who are very strongly against vaccination?
Well, I think the most important thing with patients who are very strongly against vaccination is don't try to debate them, but really explore the concerns that they have. For example, you could start a conversation by saying, I would like to understand your decision. Could you tell me something more about this? And then when they talk about their concerns, I think it's important to acknowledge their concerns. It's also what we saw in the presentations before. So you could acknowledge the concerns that they have, but it is important also to ask for their permission to share your view or your knowledge about this. So for example, you could say, I can see that you have done a lot of thinking about this and I feel that you have a lot of concerns, but could I maybe also share my view about this? And then, of course, you can share your knowledge, your expert opinion on this, and also give your strong recommendation for vaccination. But of course, if they still have strong concerns and don't want to vaccinate, you maybe won't be able to convince them right there. So in that case, it's important to respect their decision, of course, but what you can do in that case is also to inform them about the consequences of their decision not to vaccinate. So that's also something important that you could let them know what the risks are of vaccine refusal. So I think that is an important piece of information that you could share. And then, of course, if they still don't want to vaccinate, you can just respect their decision and maybe at the end of the conversation, let them know that the door is always open, that they're always welcome to come back with further questions or concerns that they might have. So I think in general, the most important thing is really to acknowledge their concerns, give the information that you have, give your recommendation, but respect their decision and inform them about the consequences of not vaccinating.
Okay, thank you. Are there any questions from the audience? And I'm hoping there will be many. You can go ahead with the microphone that's in front of you.
Yeah, thank you. I'm Jacques de Heller. I'm from Switzerland. I'm a GP. And I want to be a bit provocative because I appreciate all I heard and politeness and being nice with patients who have completely strange ideas and please try to listen to me. What I saw on the slides is the fact that it's not our efforts who changed vaccination rate in the COVID pandemic, it's the pass. The obligation to have a pass to go to the movies, to go to the restaurant, to go to any music festival. And at some point, I'm just wondering, and I'd like your reaction on this, if we should not just be clear and forget a little bit about political correctness. I mean, it's nice to be nice with patients, but facts are fact and science is science. And we are here to say that science and facts are what they are, period. Very nice to listen to patients, but I mean, come on, stupidities remain stupidities, whoever tells them, being Putin or a patient. and I mean, why can't we be ourselves and really reaffirm what we know? It's quite striking. On all the slides of Heidi Larsen, I think it's slide 18, we saw that additives are the smallest problem. It used to be the huge problem, aluminium and mercury and stuff. It's the smallest problem. And incredible theories are the biggest problem now. So I'd like to have your reaction on being true to our own knowledge, to science, to what we think medicine is, and be maybe more affirmative than politically correct.
We have someone in the audience who would like to respond.
No, I would like to emphasize Jacques' idea, which I think he's perfectly right, but it is an entirely medical point of view. And I think there is one item missing, which we experience in my home country, Germany, to an extreme extent, and that is the aspect of adequacy and proportionality as it is seen by lawyers. It is totally impossible in Germany to infringe a mandatory vaccination. We've had a very interesting discussion on this in Oslo last year. And under adequacy and proportionality aspects, lawyers, courts, judges, more or less wreck all the legal initiatives which we as physicians take and think they are important. Therefore, Jacques, although you know we are almost never of different opinions, almost never, I would say from a purely medical point of view, you are right. But we will never be able to force a patient to be vaccinated. All we can do is we can either convince him, which I think is the most important and best way, as it worked in our private lives in the past. Sometimes we may seduce them, but we will never be able to do it against their will. That is, I think, one of the problems. And therefore, we have to discriminate the people in the group of the non-vaccinated. There is I call it 5%, 10%, I don't know the exact figures. People we will never convince for ideological reasons, for whatever. But there is a small group of people who sort of follow them without being 100% convinced. So we have to reach these people, get these people to simply help us get over the 85%, closer to 90 or even over 90. How can we do that? That is the basic question. And I think seduction and conviction are the only things we can do.
Is there anyone of the expert panel that would like to comment on that?
I've been a big fan, a big advocate of listening and patience, and mostly that was coming in, and my book Stuck also was very much about that, but it was really mostly focused on, there's this huge group of people between the, of course I'll take it, and the, I'm sorry, it's going to put a chip in me, or for a million other reasons. But I think one of the things we just have to be careful of is not losing that middle, that movable middle, as they say. So I think it's absolutely important to, as a doctor, as an informed evidence professional, which is why why you're trusted. That shouldn't be it shouldn't be an instead of. I think, but in the current environment, at least the gesture of listening and hearing out where people are, because you don't know where they are on the spectrum. And I think what's happened is a few too many times, people who are asking actually quite genuine questions and actually really want to get vaccinated but are anxious. Sometimes they've been labeled or shut down because, oh, you're, as one woman told me, they treat us like we're a bunch of flat earthers sometimes. And I was just worried, it's my first child. So I just think the listening needs to come first these days, just to make sure we're not losing someone who's actually open and willing because we're judging them because they ask questions. If it's a harder line, one way or the other, at the end of the day, should absolutely be clear with what your position is and what the evidence to be.
Heidi said a lot of the same things that I would have said also, and just again stressing the fact that among the population that to address the first point about whether it was the mandates that actually did more of an impact on uptake rather than actually what healthcare providers can do. I think that's a bit of an overstatement in the sense that there are different groups in the population that chose to get or were forced to get based on the mandate, and then many who actually didn't get it, or the mandates didn't actually, or restrictions didn't actually affect them, and then they chose or not to chose. And we found that a lot with, especially when we targeted the elderly in some countries to understand what their drivers and barriers were. And there were restrictions that didn't affect them because they didn't work, or they didn't go to shopping malls, or they didn't go other places, and they still needed to be persuaded. They needed to be reached. And just very quickly to Heidi's point, that, questions from the patient's point of view, if people have questions and they want to know from a healthcare professional, then that's an opportunity to build trust. There are people who are being defiant, who are simply arguing and are not persuadable, but generally those are a very small percentage. There are this movable middle, as Heidi mentioned, but also importantly is to remember that from their perspective, insisting that they just blindly trust experts, I think is a dangerous argument to put forward, just in the sense that we all know that doctors make mistakes. Scientists have done things in the name of science that have been harmful. And that's not to say that it's, not trying to compare or single anyone out or anything like that. It's just simply a notion of building trust as a healthcare provider, not just as a scientist as a label, but actually as a human being who has expert knowledge, who actually knows what's best for the patient. And in order to be able to transmit that, to convey that, you do have to be able to listen, as Heidi said, and you have to be able to respond. And the burden isn't not completely on healthcare providers to change people's minds, but it's recognizing that there's a powerful opportunity for you in a very short amount of time to respond well. That has not only an implication for that specific conversation, but actually can have longer impact and broader impact on that person's perception of healthcare professionals in general, of the health system, of medicine, of things that are going to be better for them moving forward. And so just to encourage to think of it that way, and not to fall into too much of a binary thinking of either people are completely trusting and don't need persuasion and they just do whatever we tell them, or they are difficult and they're hopeless and we shouldn't be able to have to deal with them. So just to avoid that type of thinking, that's all I wanted to add.
So Heidi and Brett said a lot of great things, but I think I just wanted to also add to that, addressing the sort of point that was made about political, should we not worry about political correctness? I think I see it more as it's not political correctness, but a way for you to ease the science in. So instead of coming straight at someone who says something that's a very strikingly anti-science position, it's about finding commonalities to see what's actually driving that and acknowledging maybe it's fear, maybe it's normal that they are concerned. And if that bridge can be built, then there's a better chance to actually put forth, to affirm the science that we all know is supporting the vaccines. Also to address the point made in the chat that people are expecting the doctor to do all the work in persuading the vaccine hesitant patient, I can see how it can feel very annoying that the sort of doctors are in that position where they have a lot to deal with already. And this is just one more piece that they have to do in a very short time. I think that the communications actually is for everyone. I think Brett mentioned that this because healthcare providers, be it GPs, nurses, anyone delivering vaccines just happen to be in that position where it's a context that you're going to be, where vaccines are going to come up. And there's this higher level of trust in general that we consistently find in healthcare for healthcare professionals. So that does give them the power. But I also think that this doesn't occur across the board. In some cases, it's family, it's friends, it's community leaders who can make more of a difference for individual people. So I do agree that the techniques we were talking about can be usable and indeed are designed to be usable by many people, not just healthcare providers. And all of this comes together as one piece of the puzzle. And again, all the points brought up about listening, I think that's really important because of how it impacts trust. I was actually just reading something this morning about how countries that had better levels of trust, and it's not just trust in systems, but trust in each other, ended up with better outcomes in the pandemic. So I think that just really underscores this need for communications to help build that trust going forward, rather than relying on, say, mandates, which may work in the short term, but we don't know what the longer term consequences of that will be. We saw the paper that Heidi mentioned that looks at, well, is this going to affect the delivery of other vaccines, for example, having forced people to get the COVID vaccine? Will they then react and resist future vaccines? We don't know that yet. So I think that listening still ultimately is a more powerful tool in the longer run.
Thank you. We have a question from the audience.
Well, it's more an observation. I'm a GP in Dublin, and our adult fully vaccinated percentage is 95.9% in Ireland, and booster is at 77% of the clinical eligible population. I'd echo everything you say. I'd make an observation that the ones that have successfully had the higher rates are general practitioner led. And basically, so for example, we continue to meet people who will now get their first vaccine. We never gave up on them. We've always been respectful, polite, listen, document what they do, and often, echoing what somebody else said there, it's the family who finally have persuaded them, because they're the person who's often brought the infection into the family at a later stage.
Thank you for that comment.
Jean-François Rowe for French Medical Council. I have two questions, one particularly for Heidi. I have seen the map on the agreement with the vaccine, and France was the first, with 41 against the vaccine. I think it was at the beginning of the COVID, because before the vaccination, many French was against, but now we have 81 people in France who are vaccinated. I think that the situation in France has greatly evolved since the start of COVID, and the vaccination obligation was for me the major condition for people to get vaccinated. And my second question is for all, following the current tragic events, do you know why in Ukraine people are so poorly vaccinated against probably COVID, but also measles, tuberculosis, and poliomyelitis? Thank you.
I can start with a response on the first. The map, which had the 41% saying they did not agree that vaccines were safe in general. This was done in 2015. This was a global mapping of overall people's confidence in vaccines. And the second slide I showed was the update in 2018. And already the background, the confidence was already starting to get better in general. So I just thought it was important to put the COVID-specific issues in the context of background vaccine confidence, because we did see some correlation with how people were feeling before COVID about vaccines. Obviously, it's changed the landscape a lot. Others can probably speak more to this, particularly WHO colleagues. Ukraine, since the years when I was working in UNICEF 20 years ago, we had issues in the Ukraine, initially around measles vaccine, but there's been a number of other ones for different reasons. There was one adverse event that got kind of put out of proportion that scared the public, but there have been various issues politically, and also issues around feeling like even though generic vaccines were available to them, they wanted Europe-made vaccines, but didn't have the budget for them. So there have been various issues, and they have been sometimes public anxiety, sometimes political decisions. But I would turn to my WHO colleague who might have more on that.
No, thanks, Heidi. I think you put it fairly well. Just to add that, again, it's sometimes a history of different events culminating to a general perception in the public that affects many. Again, it erodes trust, and the trust can be not just only in vaccination, but in other health services as well. And things like generic vaccines speak more to not just the quality of the vaccine itself, but the perception that the people's needs aren't put first or aren't valued enough for higher quality medical products. Sometimes it's more at an institutional level where even prominent members of the medical communities are not confident in vaccines or even take an anti-vaccination stance, and can be influential that way. So it can be multiple different factors, as well as one thing I'll just note during the COVID-19 vaccine rollout, that there was hesitancy among some health workers in Ukraine, for example, that the news that some of the COVID-19 vaccines had finished phase 3 clinical trials and that they were being rolled out, the results of the third phase of the clinical trials hadn't been in the news in Ukrainian. They had been news in English and even in some Russian sites, but those who were primarily accessing certain language, news in certain languages hadn't seen that, and they were convinced that the trials hadn't been finished, that they'd been skipped, and talking about Pfizer in particular. And so sometimes we find that, unfortunately, misinformation or a lack of information in certain languages, sometimes the misinformation in some languages gets translated and spread much faster than official information can reach people. And so it's a combination of different factors in that way.
Thank you for that comment. I just wanted to say that Hedy will need to step out of the meeting due to another meeting, but maybe we have time for one or two more questions. Let's go ahead.
Jan Aaltonen from Finland. At least in Finland, there are surprisingly large number of people who are not against vaccinations in general, but they are against COVID vaccinations and all COVID vaccinations. What do you think? Why is it like that? And what could we do better in the future to avoid this kind of a situation? Thank you.
Is there anyone on the expert panel that can comment on that? Brett?
Just briefly share, just quickly share, and not from Finland, but from learning from other countries, is that a distinction is made between new vaccines and the proven vaccines in many people's minds. And we find not only with COVID vaccines, but actually with others like HPV vaccination introduced in some countries, there is a perception that they are not yet proven, and that it's only with many, many years of use, and almost like people are used to or accept the routine immunization that's been around a very long time, that, well, yes, okay, we don't question that, but anything new seems experimental and seems dangerous, and perceptions of the COVID vaccines being rushed out, that steps were skipped in the production. So there's a lot of that information or that perception that remains even after such widespread use of COVID vaccines. What people still tend to hang on to that have reservations about it are the fact that, well, you still can't tell me what the long-term effects are of these vaccines, and that's what they hang on to. And so that differentiation between something being new seems experimental versus something that has been used in a long time can still remain. As far as what to do moving forward, and I'm hoping maybe some of the other colleagues on the panel can help with that as well. But again, it's that transparency of the process of education of how vaccines are developed and how they are tested and how we know what we know. Not just saying, trust us, it's safe, but actually being very transparent about processes, and compared to historically other vaccine development and how we know it is what we know, is very helpful for the public to be able to follow along. So over to others, hopefully they have something better than that to add.
Well, I think that was great already, Brett. That's a very key, important part of explaining to people, well, what was the steps involved, and also how other vaccines used to develop and why exactly that was so slow. So I think one thing that people don't realize is maybe half the time spent developing vaccines might be trying to secure funding, trying to secure grants, trying to secure participants, and all of that was sped up. But that just meant you could do the same process, the same rigorous process quicker, because you didn't have, say, barriers in the way and people were throwing funding at it. So if it's a case of money, that's not really about rushing the process. It's just about giving more resources to people developing them. And I think maybe the other thing we could be better prepared about is to just to acknowledge that, yes, it seems rushed. We can see why it seems rushed. These are the reasons it isn't. But this is also the reason why we need to rush it, because we don't know the long-term effects of COVID either. I think we need to reinforce the fact that actually, if you're worried about the vaccine, there's also this other flip side, which is, what is the vaccine trying to help you with? And that's to try and, we know more about the vaccines than we know about COVID, because COVID is new. We have no idea what the disease is going to do to you long-term. And it's now coming up, a lot of impact, a lot of long-term symptoms, and we don't know who it affects or who's more likely to get that. But we know from a lot of decades of vaccine research that this is built on, that the likelihood of long-term effects is less with the vaccine than with COVID. So I think it's not about trying to minimize what people's concerns about long-term effects and what the vaccine might do going forward, but also recognizing that, yes, it's a possibility. Considering what we're up against, do you really want to take the risk of something you don't know versus something we at least have some good information about?
One of the differential characteristics of the COVID-19 vaccine is that it has been politicized. And that's something new. It's new in the European context. Heidi knows a lot about how the polio campaigns have been politicized in other countries, in Nigeria, Afghanistan. But in the European context, we're living now a politicization of a medical intervention. And that's something new for us, and that's why it's so surprising. And new phenomena arise from there. For example, group struggles, identity conceptions. So what we are seeing now with the COVID-19 vaccine, in my view, is what happens with when the scientific discourse becomes relevant in the public sphere, and the party struggles, the political arena, and how it works. So many of the already existing myths about other vaccines, that rhetorical tool is being used now for the COVID-19 vaccine. For example, myths about infertility were very common in Africa. Now we're seeing how they are being used against the COVID vaccines. And well, the level of politicization is different between across countries, but you can see a correlation between the level of polarization, of political polarization, and vaccine hesitancy in different countries, because there are some parties that defend the vaccine, some other parties are against the vaccine, and that's something new for physicians. I think in doctor consultation it was very uncommon to discuss conspiracy theories, political ideologies, strange conceptions about scientific knowledge. And that's something new for physicians, and I can understand the difficulties of addressing that very awkward and uncommon arguments in your consultations. And that's why we need more a new level of expertise to address these vaccine concerns, specific of the COVID-19 vaccines.
Okay, then I think we should close down the session because we have earned a coffee break. I'm handing the floor back to your president. Thank you very much for your attention, and thank you to CPME for having us. And I hope you enjoyed the session.
So thank you very much for these presentations and a very fruitful discussion. I think it's very important that we see the dilemma of what is actually what you said is new from patients who totally irrationally don't want anything, and we're quite used, they normally would believe us, and that's a new phenomenon that makes it tricky. And I think the comments from also of our past presidents were very realistic. We have to deal with that. It's the new way, but we have to work on it. And now this IMMUNION project is for 2 years, but also in CPME, we think this address to public awareness on vaccination has to move on, even also after IMMUNION. So we also have to think about that for all healthcare professionals actually in the world. So thank you very much for this wonderful session. We have now a coffee break. Coffee break will be at the beginning, what's called the bar here. That's there, it's ready. And we will reconvene at 11. Thank you.